I started my career at Queen Mary University and then spent about 11 years at the London School of Hygiene Tropical Medicine before coming back to Queen Mary and linking up with my old team. So in the UK and worldwide, we have endured tremendous shocks to our health and social care systems over the past decade and arguably even longer. We've seen drastic cuts in funding to our services, changes in government priorities, the pandemic, and more recently, the cost of living crisis. And these shocks have highlighted the important role of research in identifying and tackling these ever-evolving challenges. We're lucky to be living in a time where data are increasingly available, providing novel opportunities for the research community to drive innovation by harnessing the power of routine health and administrative data. Qualitative and quantitative approaches are being applied synergistically to shine light on the most pressing issues facing society and informing holistic approaches about how to tackle them. Our research culture has evolved in important ways, accelerated by the need for highly responsive research guided by strict ethical and governance frameworks. Over the course of this talk, I will draw on the experiences of myself and my colleagues to discuss how we transform research into action, how the pandemic has created new opportunities and ideas for research, how this has spurred new ways of thinking about tackling the wider determinants of health, how we're making use of these new approaches to support recovery from the cost of living crisis, and some future directions and lessons learned. So research to support health and social care resilience, recovery, and renewal isn't a new concept. And the organization where I'm based, the Clinical Effectiveness Group at Queen Mary University of London, has been delivering research to support health and social care for over 30 years. CEG turns electronic health record and linked social care data into actionable insights and innovations, thanks largely to the multidisciplinary efforts of data scientists, analysts, clinicians, and facilitators. And in doing so, they support a learning health system, which has shown remarkable success in improving health and reducing inequalities in one of the most ethnically diverse and socially deprived areas in London. So we've heard a lot about learning health systems over the course of this conference, and we've seen some examples of great work being undertaken all across the country. But broadly, learning health systems provide a really valuable mechanism for linking research to policy, clinical practice, and public health improvement. And this is because learning health systems offer a systematic approach to iterative, data-driven quality improvement. And this is achieved by incorporating a continuous cycle of analysis, feedback, and interaction to monitor outcomes, conduct evaluations, and implement changes. And this transforms data into knowledge back into practice through this cycle. So one key example of learning health systems at work is that of addressing inequalities in vaccinations and immunizations. So between 2006 and 2008, Tower Hamlets, where we're based, had the highest rate of confirmed measles in the UK, with 24 cases per 100,000, compared to a national figure of 2 per 100,000. Using our high-quality routine primary care data, we were able to show that there were significant ethnic inequalities in MMR vaccination uptake. And we were able to pair our quantitative work with focus group work with the Somali community, which suggested that MMR uptake was particularly low in their community, partly driven by safety concerns related to autism. And thanks to the high quality of ethnicity recording in our local area, which at the time was over 97% complete for children under 5, we were able to analyze data for the Somali ethnic group separately from the broader ethnic category of Black African Caribbean, able to demonstrate the vastly lower MMR vaccination rates in this local community. So we implemented a quality improvement intervention for all childhood vaccinations in 2009, with MMR vaccination chosen as an early marker of success. The components of our learning health system-based intervention included community engagement, dashboards to provide monthly feedback of data, call and recall activities, and shared learning across participating practice, ensuring that the cycle of feedback was complete. And importantly, we also had financial incentives for achieving herd immunity in each of the practices. And by 2011, just after this graph finishes, Tower Hamlets had achieved herd immunity and had the highest rates of MMR vaccination in the country. However, changes in management and the withdrawal of financial incentives meant that the gains were not sustained long term. 10 years later, immunisation rates in London had dropped again to the lowest in England, partly related to the pandemic. Inequalities widened, as exemplified by this map of hotspots of high MMR risk, shown to be patterned by geography and deprivation. And this prompted renewed efforts to reach herd immunity, building on a strong evidence base that call and recall initiatives can be effective, and particularly so in urban areas with diverse populations. So in February 2022, the Clinical Effectiveness Group launched a quality improvement program to address the falling rates of immunisation. And this work was led by the Child Health team, who are sitting here today at this conference. And so I'm speaking about this work on their behalf. So this intervention was funded as a Pathfinder project via the London Health Data Strategy and had the dual aim of increasing immunisation rates and reducing inequalities. The intervention comprised a toolkit for GPs practices with two main elements aiming to improve timely call and recall and equitable delivery. First was a novel purpose-built call and recall tool called the Active Patient Link, or Apple IMS tool, which was used to prioritize appointments. Second was one-to-one support and training from CEG facilitators to practice teams to download the tool and to use it effectively. Preliminary of the results of the evaluation show evidence of improvement in the practices using the tool and receiving facilitator visits. And research is now underway to evaluate the program and will generate the evidence base for practice and policy going forward. We've also had really important qualitative engagement with our local community and had some valuable insights into the program. The qualitative findings have highlighted challenges with using the tool, but also many compliments and suggestions, all of which can be taken forward in subsequent iterations of the intervention. So I've discussed how learning health systems can support the transformation of research into actionable insight for continuous improvement in health and social care, and in particular, the importance of these locally led approaches in response to health inequalities, which worsened during the pandemic. However, the pandemic itself was also a catalyst for change in research culture. The urgent need for responsive research led to widespread changes in how we use, share, and think about data in a way which has shifted the research paradigm, I think, for the better. I've conceptualized these changes into four broad categories, which I'll speak about in turn. First, the pandemic resulted in initiatives which improved the speed, safety, and transparency of research. Secondly, it put inequalities research in the spotlight. Third, it led to widespread collaboration across sectors and disciplines. And finally, it required us to build public understanding and hopefully trust in the use of health and administrative data for research. So as a health researcher by background, one of the main data sets I use is the CPRD, and I'm sure similar to many of the other databases that we use, there is a model where researchers apply for access for specific projects, and de-identified data may be sent to researchers for use. In the Open Safely model, we take the analysis to the data. And this approach allowed researchers to analyze data within the server where the data was already stored and allowed us the opportunity to conduct research without ever having to actually access the raw data. And on 7th of May 2020, the Open Safely collaboration preprinted the world's largest study into factors associated with COVID-19, a mere 42 days from the inception of the platform. And this was made possible by huge collaboration between Oxford, the London School of Hygiene and Tropical Medicine, NHS England, and GP software provider TPP. And the speed at which the research was conducted was thanks also in part to Open Safely providing real-time data, which was and still is refreshed on a weekly basis, which at that time was an unheard of model for researchers such as myself working with electronic health record data. So how does the Open Safely model work? So as I mentioned, Open Safely does not move patient data outside the server where it already resides. Instead, users of Open Safely develop their analytic code on dummy data using open tools such as GitHub. Analytic code is developed and tested on the synthetic data in your own local environment. And when you're happy with the code, you pass it back through GitHub to the TPP server, and it's run against the real data. At the end, the outputs are sent back to the researchers, and they must be manually checked for disclosivity before being released publicly. So why this emphasis on keeping raw data at an arm's length from researchers? Well, of course, there have been significant concerns about data breaches and the safety of individual patient data. And of course, we also had the Surgisphere scandal, which produced fraudulent papers. In contrast, the Open Safely model aimed from the outset to be provably trustworthy and transparent. All projects within the Open Safely system are visible to the public, and all researchers must publish their analytic code in order to run their analyses. And these code must be published under an open source license. And this allows patients, professionals, and the public to hold the entire system accountable because it's their own data being used for public benefit. So the work of Open Safely and other similar initiatives have had a significant impact on research using administrative health and social care datasets. There was already a growing consensus among journals and funders that sharing data is best practice for public accountability and patient outcomes. But for those of us who use routine health and administrative data, sharing the underlying data is a legal impossibility. However, sharing the code that we use for data management and analysis is within our gift and has been normalized by initiatives such as this. And journals such as the BMJ and PLOS Medicine, amongst many others, have made a move to mandate code sharing to improve transparency, facilitate peer review, and allow all of us to learn from and build on each other's best practice. So a second key paradigm shift resulting from the pandemic was the sudden spotlight on inequalities research. And I know this sounds strange to all of us sitting in this room who've probably been working on inequalities, as a thread throughout all of our work. But at that time, when I was working particularly on ethnic inequalities, that kind of thinking wasn't in the mainstream. And so all of a sudden, going from a somewhat sort of niche project to something of national interest was really a huge shift for all of us. And so, because of that, hot on the heels of the first Open Safely publication, and in light of growing evidence around ethnic inequalities and COVID-19 mortality, we embarked on a huge collaborative effort to investigate ethnic inequalities in the COVID-19 pathway. And this was made possible by the large number of real-time linkages available to us under the COPI notice. We linked primary care and hospital care data to testing surveillance data, ICU admissions data, and mortality data for 17 million adults in England. And a key addition to our analysis of ethnic inequalities over and above what had already been published up until that point was the availability of household size data. And this was made possible because TPP had access to the identifiable information on their servers where the data was held. And they were able to create an anonymized identifier for people who had the same address. So while, of course, this may have been prone to errors, we were able to broadly estimate ethnic differences in household size. And as you can see here, people of South Asian ethnicity in particular were significantly overrepresented in large households compared to white groups, though proportions were also raised for other minority ethnic groups. And thanks to the large sample size of 17 million adults, we were able to undertake comparisons not only between the 5 high-level ethnic groups, but also between the 16 more granular groups of the census. And this was something which had not been reported yet in a UK setting. And this allowed us to identify widening inequalities in COVID-19 mortality between the first and second waves. And we found that this was true for South Asian groups, but not other ethnic groups. And with our granular data, we could also see that the increase in mortality relative to white groups was driven largely by the Bangladeshi community. And this effect was apparent after accounting for demographic and clinical factors, including household size. And importantly, we showed for the first time that household size was an important predictor of COVID-19 mortality in South Asian groups, but not in other groups. And this allowed us to generate some hypotheses for what the mechanisms might be. So this led to some follow-on work in Open Safely, led by my colleague Kevin Wing, who refined the crude household size variable I had used into a measure of multi-generational living. And Kevin's study found that 66% of people of South Asian ethnicity lived in multi-generational households, compared to 23% of white groups and 49% of black groups. The study demonstrated that multi-generational living and living alone were both associated with an increased risk of severe COVID-19, with South Asian groups overrepresented in multi-generational households and white groups overrepresented amongst those living alone. So where next? The collaborative way that we were all working during the pandemic meant that we were working closely alongside colleagues from the ONS, sharing our results on an almost weekly basis. And thanks to the high-resolution information from them, the ONS colleagues led the next phase of the work, evolving our approach to now consider much more detailed information on overcrowding and individual level factors such as employment, education, and whether or not someone was a key worker. And they found that even after accounting for all of these much more highly refined measures of deprivation, ethnicity, and household status, living in multi-generational households remained an important predictor of outcomes for South Asian groups. And our collaborative approach allowed us to transform our research findings into responsive policy recommendations around not only the increased risk of exposure in large multi-generational households, but also the benefits of these highly networked households and communities, and sharing key messages around prevention and ultimately vaccination. So this collaboration was spurred as part of my activities as part of the SAGE ethnicity subgroup, which brought together people from academia, government, charities and education, and housing sectors. And research from our social science colleagues brought in the voices of communities so that we could understand social and cultural realities of different communities alongside the quantitative research that we were undertaking. And together, we produced policy briefings, news articles, reports, and commentaries, which were all essential to build the evidence base on a timescale much shorter than publishing academic peer-reviewed papers. And this again represented another paradigm shift in how research was being transformed into policy to support recovery and resilience. And together our findings showed, I'll just read it here, when household, family, and community structures combine with greater occupational exposure, structural racism, and poorer housing conditions, they result in particular disadvantages for ethnic minority populations. We need to acknowledge that the health disparities result from multiple intersecting forms of disadvantage. So the final paradigm shift that I'm going to speak about is how the pandemic ushered in public awareness of how health and administrative data are being used in research. This report from the NHR, reporting back on 3 citizens' juries, reported broad support for initiatives such as Open Safely and the NHS Data Store, and understanding of the importance of data sharing. And it's certainly my hope and all of our hopes that this understanding evolves into trust. And the pandemic has brought to the fore the importance of communicating our science to the public, and that responsibility lies with us as researchers to bridge that gap. So where next? The pandemic changed how we conduct research, collaborate, and communicate our findings. And while the pandemic compounded existing health inequalities, it also gave impetus for thinking about tackling the wider determinants of health in new ways. So, as in the example before, COVID-19 helped us think about the importance of households with respect not only to transmission, but also the role of households in providing social support. And this gave impetus to develop new methods to examine household influences on health outcomes. And this resulted in an ADR UK funded collaboration between Queen Mary, Swansea, and Edinburgh to link together health and household data. And this initiative was made possible because of the COPI notices which came around during the pandemic, which allowed the linkage of identifiable data. And this collaboration built on over 14 years of experience brought from the collaborators at the Sale Databank. So this research began with thinking about how we can bring data on unique property reference numbers into the health record. So households were derived from the unique 12-digit UPRN, which is a unique identifier for every addressable location in Great Britain. Households were linked to primary care records using a validated algorithm called ASSIGN, and the household UPRN was pseudonymized for use by researchers accessing the linked primary healthcare record. So this new linked resource for North East London has several applications which are now being taken forward, and we're hoping that this new resource will allow us to characterize household composition, create a measure of adverse household environments, examine associations with social health and geographic outcomes, and build public trust in the use of address-based data. So one piece of work conducting this new linked resource is mapping household overcrowding in East London. And you can see that these maps here demonstrate striking increases in overcrowding as measured by the bedroom standard measure and also the London space standard measure. And having access to data such as these opens up many new opportunities to examine the impact of household crowding on health and social outcomes. There are several further projects planned using these newly linked data, mainly around looking at the association between adverse childhood outcomes with mental health and well-being, educational attainment and attendance, and receiving safe care and support. And these projects are being taken forward by my colleagues in the child health team, and I'm sure that over the course of subsequent conferences, you'll hear more about the results of these very exciting projects. Innovations and methods are also being used to support recovery from the cost of living crisis, and I'll just mention a couple of projects that CEG are working on in this space. So the first is a research program called Making Ends Meet, which looks at the association between self-reported financial status and health. And this work builds on previous literature, which has suggested that self-reported measures may be more closely linked to health outcomes than standard area-level measures. And as we all know, this is because area-level measures can substantially underestimate individual-level deprivation, and therefore may underestimate the impact of risk factors for certain diseases. And this is particularly problematic in urban areas, such as North East London, where we're based. So CEG implemented a study where they asked this question about people's difficulty in making ends meet and found a very strong correlation between the individual level question and health outcomes compared to the area level IMD. And in fact, we see a much greater scale with the odds of the association being between 6 and 12 for the self-reported measure and much smaller for the area level measure. So a second example of how research is supporting recovery from the cost of living crisis is the evaluation of free school meal policies. And this work is funded as part of the NIHR Health Determinants Collaboration Award, which was given to Tower Hamlets Council as part of an overarching program of work tackling the wider determinants of health. So CEG has been funded to lead the evaluation of this program in primary schools and soon secondary schools, and we'll be able to share the findings of these projects soon as well. So just to close, some future directions and lessons learned from my own journey through this experience. So key to sustaining the cycle of impact, research and policy is capacity building for the next generation of clinical, community and research leaders. We at Queen Mary offer a master's and PhD program in health data in practice. And I think one of the things that makes our program distinct from other health data science programs that I've seen or have been involved in is the explicit focus on interdisciplinary training and a strong focus on the use of routine administrative and health record data. And our students undertake a wide range of PhD projects, ranging from qualitative approaches, machine learning and AI, to making the best use of linked administrative and health data to answer complex questions using novel methods. We're also ensuring the future of research to support health and social care by sharing our learning internationally. So we have a collaboration with Chiang Mai University and the London School of Hygiene to think about, can we implement a CEG-style learning healthcare system in Thai primary care settings? So Thailand has a very well-funded health and social care system, but is new to using real-time data to support patient care and quality improvement. So we want to share the CEG learning health system model, learn about what works well for them in relation to long-term conditions as shown here on this slide. And this will allow us to determine whether things that work well for us in the NHS adapt well to other settings, and what other local challenges do we need to consider when looking at the transportability of learning health system approaches. So you'll see some very familiar components of this intervention from what I spoke about at the very beginning of the talk. So building on the CEG model, the Thai intervention will take forward key elements of our learning health system approach, including extensive stakeholder engagement. We already have buy-in from the Thai Ministry of Public Health and the World Health Organization, development of new computer tools, training, facilitation, and regular feedback, and embedding a culture of shared learning to drive quality improvement. So, just to close, I just wanted to share some summary of what we've spoken about today. Research to support resilience, renewal, and recovery needs to consider the wider determinants of health and identify actionable targets for intervention. Learning health systems can support this approach via a cycle of transforming data into research, into impact. Multidisciplinary and multi-sectoral approaches must be applied synergistically to tackle complex problems. And we've seen this realized during and after the pandemic, which generated opportunities for novel data linkages, fast and transparent ways of working, and gave impetus for new approaches to existing problems. So we now need to work together across health, education, schools, and households to develop a holistic understanding of disparities in local, national, and global contexts. So thank you very much for your time, and thank you to our collaborators and our funders. I'm happy to take any questions.
Thanks very much, Rohini. That was a lovely talk, and I loved your last slide in particular. That kind of sums up the whole conference, really, doesn't it? Any questions for Rohini? Oh, yeah, here at the front.
Hi, thank you. I'm Sally Miles from the Office for National Statistics. It's less of a question and more of a kind of comment and wanting to kind of get in touch with you. So I work in a team called Living Arrangements, and we're currently trying to use administrative data to work out where people live, who they live with, and that kind of thing. So at the moment, we're trying to popularise the use of the term occupied address over household, because with administrative data, we can't actually get to the communal cooking pot, which is what has traditionally constituted a household. And we're also going to be doing some work on composition of households soon. So I'd really welcome kind of getting in touch to see what you've worked on, how we can kind of collaborate together.
Would be absolutely wonderful, thank you. And one of my colleagues, Marta Wilk, will be speaking about some of the households work that's been undertaken. So maybe
I'm planning to go to that this afternoon.
We can connect there.
Thanks very much. And next question. Yes, Emily.
Thanks very much. Great talk. I was just interested in your advocacy for the Open Safely model, and thinking about I'm particularly interested in the synthetic data side of that, and whether you kind of had any thoughts about how that sort of synthetic data option could be used more effectively in terms of data access and really just sort of getting support for public use of data in that way.
Yeah, thank you. Great question. I mean, I know many of you are familiar with Open Safely, and there are certainly downsides to this arm's length approach, having to learn lots of new tools and software. And using the synthetic data is a challenge, because I think right now the data that Open Safely generates, it looks like the real data, but it doesn't necessarily reflect the relationships between variables. And so often you can write code which is correct, but you may not know if it produces the right outputs because your models may not converge in the synthetic data, for example. So some of the work that my colleagues are taking forward as part of a PhD project is looking at whether we can develop synthetic data which can be informed by causal diagrams, by DAG. So if you input some hypotheses about how variables may be related from other research or from your own assumptions, can this create better quality synthetic data to simplify that transition from the synthetic to the real? But it'll be very exciting to discuss that more with you.
Thanks very much. And yeah, we've been doing a lot of work right across ADR UK, led by Emily, to consider how we use synthetic data to smooth the researcher journey. You know, even if it's just giving access to synthetic data where, you know, individual variables are coded correctly, but you're not maintaining the relationships, as you say, and giving them access to that before whilst they're applying for the permissions to analyse the data, and, you know, shortening the time that they actually need to be working within the trusted research environment. But yeah, really good to work with you on that, definitely. Next question. There's one here at the front.
Thank you. Great talk. You mentioned the COPI notice, and obviously the COPI notice stopped being a COPI notice. How have you found the change? Do you see things closing completely, or do you think there's still? Do you think that things are beginning to open up again, or how long term do you think the impact has been?
Yeah, this is a good question, and I think, you know, at least in terms of the work that I've been doing with Open Safe, like, we're still working on, not the COPI notice, but we're still working only on COVID-related projects, and it's been, you know, there's this itch to open up to answer other questions. And I think, you know, some of the benefits of working under the COPI notice, you know, the very fast, collaborative, the real, you know, go-getter attitudes that this is important and we should do things together. I think those approaches to working are things that we would really not want to lose. And I think there's value in saying, if we can leave aside egos and politics, whatever, actually there's so much good work that can be done, you know, while preserving patient privacy and safety.
Right. Oh, there's a question here at the front.
Hi, Rohini. Thanks for the talk. Fergus McDonald from Dare UK. I had a question maybe a little bit specifically around the beginning of your talk, where you spoke about the herd immunity and basically that there was quite a sharp regression. And you sort of mentioned fiscal, like the lack of fiscal incentives. And I'm just curious if you've dug a bit deeper into, what did you mean when you said fiscal incentives? Was that for sort of the people themselves, or you maybe just a bit deeper on what the lessons were there?
Yes, so this all happened in the interim. I worked on the first ML project, then I went to the London school and then the second project. But my colleagues working on the current project are here. I don't know if you're willing to answer.
Thanks. So the original scheme was in the days when the target was to increase herd immunity at 24 months of age. And there was a local incentive scheme which encouraged practices, so it gave them a payment for a lesser target over and above that. And one of the problems at the moment is that practices are at such a low level that they're not actually hitting any of the targets, and therefore they're actually losing money, and it's a massive disincentive. And about 2 years ago now, the Public Health England changed the targets, but they weren't really data informed. So what they were saying is that actually you're eligible for your first MMR, say, by 12 months, but actually we want you now to give it in a timely manner, which means before you're 18 months. So once a child ages out of 18 months, there's nothing you can do. You can't get that money. So you need data to turn into actionable information for the practice, but then you need to incentivize it because it's going to take some while before the practice hit the very high targets that have been set nationally. And this is a London problem, but it's actually a national problem. And there was actually an interesting article in Pulse which showed that the effect of this policy has been to widen inequalities between practices. So I think what we've faced with is a lack of willingness by our integrated care system to fund a locally enhanced scheme. So we've got some of the components, but not all the components needed for what's effectively a behaviour change model. Sorry, that was a bit long, but it's a complex thing. And it's an absolute disgrace, I have to say, that the thing that we know that is most effective after clean water for an infection that has an R value of 12 to 28, just think about that in terms of COVID, that we're not actually seeing this as a public health emergency for children.
Thanks very much. Next question. Alison, go ahead. Oh, wait to the...
Thank you very much for that very interesting talk. As I mentioned to you, my name's Alison McFarlane, and I'm from City University of London. And in the past, we collaborated more than we now do probably with Queen Mary on locally based public health initiatives, particularly in the inner East London boroughs. And one of the things that was notable, so when I originally arrived, the first thing was that Tower Hamlets was brilliant because all the GPs were on the same IT system, which is very unusual in England. If you're from Scotland, you seem to think that's quite a good idea, but it was not in England. And therefore, the sort of things that you were able to do, having this common GP system, was ahead of the game. But the other thing was the reliance on systems supplied by other providers, and particularly child health systems and maternity systems. And at the time, there were legacy systems which were inherited from systems which were actually written within the former North East Thames region, and then hospital systems which had been locally generated and written within the hospitals. As the technology became out of date, and because the regional health authorities had been abolished, the old systems were replaced by particularly child health systems, which were not fit for purpose. And I think what you've described was how you probably recovered from that. And equally, maternity systems which were completely useless. Can you tell us something about how you dealt with this interrelationship between local and national systems in order to improve what you had in the boroughs you were working with?
Thank you for your question. So I think this is really comes to the heart of what the Clinical Effectiveness Group does, which is providing support and training for practices and healthcare providers to meet not only the local but the national targets and how to disentangle the two. And so I don't know if we've got the systems working together, but I think what we do is we develop tools which help practices make sense of the disparate information and the changing targets. So I think that's the way we're doing it, sort of making an interface locally that keeps up to date with this ever-changing landscape. And I agree, it's still a huge problem, disparate systems within one healthcare setting, within one hospital. It's still a challenge that we're facing.
Thanks very much. And could you just give us your thoughts as well on the importance of multidisciplinary teams? Because you mentioned that was a feature of your master's and PhD programs. Because as a researcher, you know, I got my PhD decades ago, but, you know, back then you were expected to be, you know, a single individual specialised in your, you know, sort of chosen specialism and with all of the statistical knowledge to analyse all of the data in front of you, and nothing else would do. But I'm sort of picking up that that's just simply not possible these days. But if you'd like to offer any comments on that.
Yes, so I think our Health Data in Practice program, which was conceived and started by Carol Desito, sitting here with us, it has a really, the ethos that all data are important and all types of data analysis can be considered health data science. And so the program offers training right from the outset in quantitative methods, in qualitative methods, in computer science methods, and indeed it has a module called Health Data in Practice, which is very much about the kinds of things that we do, is what is a social context in how health data are created, what are the pitfalls of data, where do we find truth, where do we have to make assumptions, and how do these things work in real life. And I think having that contextual understanding right from the get-go sets up our students really well to think that, oh, actually, there are lots of approaches and potentially career pathways that I hadn't considered before, because they'll often come with a master's before coming to the PhD program. So it's sort of reorienting people's thinking in a way that I've not seen done anywhere else in any other program.
Oh, that sounds really good, definitely. Any final questions? Wave your hand if you if I'm not seeing you. Yes, final question.
Thanks. Thanks, Rob Baxter at ADR UK. Thanks for a really interesting and insightful talk. So during it looks like the CEG has had genuine impact, which is fantastic to see. Through the course of your work, have you come up with any magic formulae that the rest of us could copy to say, okay, from research to impact it's something we all want to see more of? Do you have a magic formula for that? Or was it a matter of the right people having the right conversations at the right time?
I don't know if it's a magic formula per se, but I think a lot of CEG success and successes from other systems that we've heard about in this conference is developing that relationship with your local community and building that trust. People are being bombarded by technology, by requirements to meet funding targets, but actually having that personal touch in a way, say, we're here to support you, we understand what you're going through here, we're doing this to help you, rather than imposing something. I think that relationship is at the core of CEG success, and I think that's something that is, quite unique and can be disseminated.
I'll just add to that perhaps the question to say is, what can I do for you? And I think that's the approach that I'm not a GP, but the founders of CEG, who are GPs, were local GPs who were trained in epidemiology and public health. And when they helped develop the data systems, they wanted to know, how can it help you work better, smarter? And so I think the GPs have a vested interest in the data being right. And so it has an impact on data quality. And then I think there's trust, so trusted system. But I think what's exciting is that the London Pathfinders had another couple of projects that we were involved in. And South East London and North West London have now funded clinical effectiveness systems, and Kent and Medway also, where one of the GPs went to. And I think there's interest in other parts of the country in this. So the IT is not a plug-in. It, without facilitation and behaviour change and that kind of sense of starting where people are in their work. So I think it's a good model. And I think we had a really interesting secondary care presentation as well from Birmingham in this conference, thinking about how that can work in maternity hospitals and secondary care. So it's really worth thinking about.
Thanks very much. And thank you so much again for your really interesting talk, Rohini, and reminding us about the importance of looking at wider data, not just health data, when thinking about health inequalities, definitely. Thank you. Thank you. So the next session starts at 20 past, so you can do your usual slow meander, talk to other people along the way to the next session, and then we'll do a short final session in here while we do the prize giving. Thank you.